Is our speaker.
Thank you, Emily. It is my great honor to present today's Grand Round speaker, Dr. Paul Aronson. Dr. Aronson completed his pediatric residency at the Children's Hospital of Philadelphia. He then completed his pediatric emergency medicine fellowship at CHOP. From there, he joined the Yale School of Medicine, where he is currently an associate professor in the Department of Pediatrics and is also an associate professor in the Department of Emergency Medicine. Dr. Aronson has been the main investigator and co-PI of local and multiple federal grants, including AHRQ and NIH grants. Among his many national leadership positions, he is currently the vice chair of the Pediatric Emergency Medicine Collaborative Research Committee, which is the PEMCRC, which is a subcommittee of the American Academy of Pediatrics section of emergency medicine. And I would add that multiple of our faculty have participated in the collaborative. He's also principal investigator of the Febrile Young Infant Research Collaborative. Among his current research endeavors, Dr. Aronson is the main PI / co-PI of REVISE 2, Reducing the Variability in the Infant Sepsis Evaluation, a national quality initiative, which our facility is participating in. Dr. Aronson has over 75 publications, and I was reviewing them the other day, and he's got multiple, at least 10 publications on the febrile infant. He's a national and international expert on the evaluation and diagnostic workup of the febrile infant. Please welcome Dr. Aronson, who will discuss management of the febrile young infant in 2022. Can we safely do less?
All right, well, thank you so much, Dr. Louie, for that very, very kind introduction. It's really a pleasure to be here. I'm going to share my screen in a moment. I was just saying to Dr. Louie and Dr. Shope behind the scenes that this is a Yale approved background. It's a hockey rink. It's where I spend a lot of my time. I'm not working clinically or doing research. And I figured for Minnesota, it would be hopefully an appropriate background. So I'm going to share my screen. And hopefully everyone can see that okay. Please just let me know if not. And then we'll go ahead. And again, the focus on today's talk is really a focus a lot around the not new anymore, but about a year old American Academy of Pediatrics clinical practice guidelines for the management of febrile infants, with really a focus on what the algorithms are, but also can we safely do less without compromising outcomes. So I have no conflicts of interest or financial relationships to disclose. I do disclose, as Dr. Louie mentioned, grant support from NIH and AHRQ previously. And as I just mentioned, I also disclosed that I am a hockey parent, as I'm sure some of you and many of you are, not just hockey, but various sports. And so that also takes up a lot of my time, which I'm happy to answer questions about hockey as well, if that is of interest. So here's our learning objectives for today. So the next time that you provide care to a febrile young infant, I would like for you to evaluate the recommendations from the American Academy of Pediatrics Febrile Infant Clinical Practice Guideline. And I'll be abbreviating that as the AAP-CPG going forward in the talk. I'd like for you to compare the performance characteristics of the newer risk stratification algorithms that include procalcitonin. I'd like for you to analyze the evidence for selective lumbar punctures in febrile young infants with positive urinalyses. And near the end of the talk, we'll discuss this a little bit, but I'd like for you to differentiate the role of viral testing in the management of febrile young infants. So just a few definitions to make sure that we're talking about the same thing, though I presume that you know this already likely. So fever, certainly in the research context, is defined as a rectal temperature greater than or equal to 38 degrees Celsius or 100.4 degrees Fahrenheit, though truthfully in clinical practice, many of us manage febrile infants the same if it's a non-rectal temperature, for example, an axillary temperature, though there is a gray area in regards to non-rectally obtained temperatures. The young infant technically includes infants up to 90 days old, though the AAP-CPG focuses on infants 60 days of age or younger. And that's what we'll focus on today, primarily because there's much less evidence to guide the management of the 61 to 90-day-old infant. The types of bacterial infection we're talking about are urinary tract infection, and then separately bacteremia and or bacterial meningitis, together of which are called invasive bacterial infection, which I'll be abbreviating as IBI. The term serious bacterial infection is no longer recommended because the guideline really, in much research, really differentiates UTI, which is more benign, from the more serious IBI. So now we're going to talk about the AAP-CPG for well-appearing febrile infants 8 to 60 days old, which was published about a year ago. So who is included in the guideline? So it's infants 8 to 60 days of age. The reason the guideline excludes the first week of life is those infants are at high risk for early onset sepsis, primarily due to group B streptococcus or GPS. Though truthfully, when an infant in the first week of life was presented to the office, to the emergency department, or to the hospital, we'd manage them very similar to what I'll show you for the 8 to 21-day-old infant. I mentioned that the temperature criteria already, which can be attained in any setting in the 24 hours prior to presentation. The guideline applies to full-term infants greater than or equal to 37 weeks gestational age and those infants who are well appearing. So who is excluded from the guideline? So the infants who are excluded are those infants who either have a condition that would potentially put them at higher risk of having particularly invasive bacterial infections. So things like prematurity, chronic medical condition, an infant who's very young or has a complicated perinatal course, certainly an infant who is ill appearing. And a lot of these infants, particularly the infants who are premature or chronic medical conditions, were excluded from many of the studies that represented the evidence base for the guideline. The guideline also excludes infants who have an alternative source of infection for whom the risk of bacterial infection may actually be lower. For infants with a diagnosis of bronchiolitis, for example, and we'll touch on bronchiolitis near the end of the talk. And infants with a specific bacterial infection on exam, for example, mastitis, cellulitis. If there's a high suspicion of herpes simplex virus infection, for example, an infant with vesicles, if the infant had immunization within the prior 48 hours, and then, although this is not an exclusion, this can be considered to be an exclusion depending on clinician's risk tolerance, which is antibiotic treatment within the prior 48 hours. So for many of these exclusions, except for bronchiolitis, we won't be touching on them today, though I'm happy to answer questions after the talk if that is of interest. So the AAP CPG is divided into 3 different age groups: 8 to 21 days, 22 to 28 days, and 29 to 60 days. And each age group has key action statements, and as well as a total of, throughout the guideline, 40 different recommendations that focus on the recommended evaluation and workup, initial disposition from the emergency department, empiric antibiotic therapy when indicated, and then time to hospital discharge for infants who are hospitalized. So this is, represents a change in that historically, we've often risk stratified infants in 2 age groups, age 28 days or below, and then age 29 to 60 days. And the guideline breaks up into 3 age groups. And this is the figure taken from the guideline itself that shows a main reason why the guideline uses 3 age groups. So on the x-axis are different research groups, including our Febrile Infant Collaborative, certainly PCAR, which many of you are familiar with, and then the combined one over on the right. And then the y-axis is percent. What this is looking at is percent bacteremia by age. So the blue bars represent age 8 to 21 days, the red bars 22 to 28 days, and the green bars 29 to 56 days. And what you can see basically is that the prevalence of bacteremia goes down steadily by the 3 different age groups. So around 4% in the infants 8 to 21 days, maybe 2.5% in infants 22 to 28 days, and then a little bit less than 2% in infants 29 to 56 days. So because of this decreasing prevalence of bacteremia, and if you looked at meningitis, the percentages would be lower, but the same pattern would be seen, that the baseline prevalence of these more serious invasive bacterial infections goes down sort of by age group. And that's why there's different recommendations by age group, which we'll be going through shortly. I'm going to be referring to inflammatory markers throughout the talk. And these are the 4 inflammatory markers with their values considered abnormal that are in the AAP CPG. So procalcitonin or PCT greater than 0.5, C-reactive protein or CRP greater than or equal to 20, absolute neutrophil count or ANC greater than 4,000 to 5,200, and we'll talk about those 2 different values later. And a temperature, maximum temperature greater than 38.5 degrees Celsius. So now we'll start with the algorithm for febrile infants 8 to 21 days old. And this is probably the most straightforward algorithms of the 3. So on the right hand of each of these slides is just a screenshot of the actual pathway taken from the guideline. But I want you to focus on the left side of the slide, which is in text, sort of breaking down what the pathway shows without all the arrows. So the recommended workup in infants 8 to 21 days is to obtain a urinalysis, a blood culture, and to do a lumbar puncture in all of these infants. And then to send a urine culture if the urinalysis is positive. And this goes for every age group, where the guideline recommends only sending a urine culture if the urinalysis is positive. And I have a slide about why the guideline sort of has that recommendation. The guideline says that you may obtain inflammatory markers in this age group. The reason it's a may is that they will often not change management, given that you're doing a lumbar puncture anyway. And as I'll show you, the recommendation is to admit the infant on empiric antibiotics anyway, regardless of inflammatory markers. And so those are really an option because they won't often change management. The guideline recommends to obtain HSV or herpes simplex virus testing if there's increased risk. I have some slides after the fact if there are questions about HSV. Just for the interest of time, I'm not talking about that today, but it's a whole topic in and of itself that I'm happy to touch on if there are questions. If you're doing a lumbar puncture, this is not directly in the guideline, but there is evidence to suggest you should obtain enterovirus and paraechovirus PCR from the cerebral spinal fluid in certain situations. The disposition recommended in this age group is to admit, and the treatment is recommended empiric antibiotics to use either ampicillin and ceftazidime, though gentamicin can be substituted for ceftazidime if you're not concerned about meningitis. Then if there's increased risk of HSV, to add acyclovir as well. So what about this recommendation about obtaining a urine culture only if the urinalysis is positive? So this is based on several studies, and I recognize this is a recommendation that I think is a challenge, at least my impression is a challenge for some emergency departments in particular to implement due to both interpretation of evidence as well as sort of functional practice. But the reason this recommendation exists is that at baseline, there's approximately a 10% prevalence of urinary tract infection in febrile infants. The sensitivity of the urinalysis is about 94%. There's a nice study out of PCARN that showed this more recently. But when you have bacteremic UTI, so that means a UTI that has a blood culture that's positive for the same organism, sensitivity is closer to 98 to 100%. So this means that if you had 1,000 febrile infants, approximately 94 to 98, just less than 10%, will have UTIs detected by a positive urinalysis based on that sensitivity of urinalysis. And 2 to 6 infants with UTI may be, quote, missed. What the guideline then, sort of doing the math, says is that an additional 200 to 500 catheterized specimens for urine culture will need to be attained to detect one additional infant with a positive urine culture. And it's unclear if this one infant has a UTI, or if bacteria that's identified in the setting of a negative urinalysis is a false positive, either asymptomatic bacteria or a contaminant. And this is the argument that the guideline really says the risk of a false positive is perhaps higher than a false negative in this age group. And that's what the recommendation is. And so I'll leave it there as the sort of evidence-based, at least that's contained in the guideline. What about enterovirus and paraechovirus? This is not directly part of the guideline, but there's been now several studies of both single center and multi-center, including a study done through the PEMCRC, that showed that a positive CSF enterovirus PCR, which often results within 24 hours, is associated with shorter hospital length of stay. The reason being the enterovirus CSF PCR comes back positive. There's a low risk of concomitant IBI when you have a positive enterovirus CSF PCR, and so the infant can be discharged home sooner than perhaps 24 to 36 hours. And so the recommendation really based on this literature is to send enterovirus CSF PCR in the setting of CSF pleocytosis all year, since enterovirus, while most common in the June to October sort of period, can happen in the winter as well. And then to send it either really in all CSF samples in the summer and fall, given that enterovirus can occur without CSF pleocytosis. Paraechovirus is sort of interesting in that, at least at Yale, and I think many sites now, often you can order enterovirus and paraechovirus CSF PCR sort of panel together. Paraechovirus occurs seasonally, approximately every other year, very similar in terms of enterovirus, and it's common in the summer and fall. So that does commonly occur without CSF pleocytosis. So this is another sort of a virus to potentially identify and discharge the infant sooner. Though more recently, this past year, I'm sure you all have seen some cases as well. Paraechovirus type A3 has been associated with pretty severe disease in neonates, particularly in the first month of life. And so we've had several infants who've had very, very serious, critically ill disease from paraechovirus. Unfortunately, there's no direct treatment for it, but this is something you may see and you probably did see over the summer as well. So now I'm going to move to the algorithm for infants 29 to 60 days old. I'm saving the 22 to 28 days old to the end, since that's the algorithm that has probably the biggest change in relative to what's historical practice. And I think a lot of the evidence base for the infants 29 to 60 days old also applies to the 22 to 28 day old age group. And so the recommended workup in febrile infants 29 to 60 days is very similar in some ways to age 21 days old, and that a urinalysis and a blood culture is recommended, with a urine culture to be sent if the urinalysis is positive. Then it's recommended that inflammatory markers are obtained with the blood culture, and that based on the inflammatory markers, the next steps in management are determined based on those values. So if the inflammatory markers are positive, what the guideline says that you may perform a lumbar puncture based on risk tolerance, based on parents' risk tolerance. And I will say that I think this recommendation to me, and I'll show you some evidence behind this, depends on which inflammatory marker is positive in terms of doing lumbar puncture or not. But the guideline really says you may, so it's not a must, it's a may. Disposition, if the lumbar puncture is performed and you're concerned about meningitis, you should admit that you may admit if inflammatory markers are positive. Again, not a must, but a may, though I think many of us will admit in practice an infant with positive inflammatory markers in this age group. And treatment that you may use ceftriaxone if the inflammatory markers are positive and the CSF, if obtained, is negative for empiric treatment of bacteremia. And then to use vancomycin plus ceftriaxone or ceftazidime if you're concerned about bacterial meningitis, so using broad spectrum antibiotics in this age group. The point here is that in the setting of positive inflammatory markers, there's a lot of may statements in the guideline that you may obtain lumbar puncture, you may admit, you may use antibiotics, though I think in practice, it will be dependent on the inflammatory marker that is positive, and I'll show you some evidence behind them. If the inflammatory markers are negative in this age group, even if the urinalysis is positive, the guideline strongly recommends not to obtain a lumbar puncture, and I'll show you some evidence for that recommendation. You can discharge the infant if the inflammatory markers are negative. If the urinalysis is negative and the inflammatory markers are negative, the guideline recommends no antibiotics. While if the urinalysis is positive and inflammatory markers are negative, the guideline recommends treatment for a presumed UTI with oral antibiotics, either cephalexin or cefixime, and most of us, I think, use cephalexin because cefixime is not easily obtained at a pharmacy. I think functionally, certainly, often these infants have an IV already from doing the blood test. And so infants who have presumed UTI and negative inflammatory markers may get a dose of IV ceftriaxone before being discharged on oral antibiotics. That's a practice that I've certainly seen and have adopted myself as well. So in terms of the inflammatory markers, I showed you the 4 inflammatory markers before. What the guideline recommends, this is an important point, is that if procalcitonin is available, you should use procalcitonin with ANC plus or minus CRP and not to use height of temperature. If procalcitonin is not available, then the guideline recommends using temperature in combination with ANC and CRP. So if you have procalcitonin available, the reason temperature is not recommended is that, and I'll show you the algorithms for procalcitonin, the temperature will not really increase the sensitivity of the procalcitonin-based risk stratification, but may actually reduce specificity, which could result in more lumbar punctures and more hospitalizations. Just to be very clear, temperature should not be used if you are using procalcitonin for risk stratification. Again, here are the 4 inflammatory markers and what's considered the abnormal values in this age group. So now let's look at the newer risk stratification algorithms that include procalcitonin. Though now these algorithms are actually several years old, though are increasingly being adopted across the US. So the first procalcitonin-based algorithm that was used was the step-by-step approach, which was validated prospectively by Santiago Mintegi and others in the Spanish emergency group about 6 years ago. So what this algorithm says is the infant ill appearing? If yes, they're high risk. If not, are they aged less than or equal to 21 days? If yes, they're high risk. Do they have leukocyturia, so a positive urine dipstick? If yes, considered high risk. Do they have a procalcitonin greater than or equal to 0.5? If yes, high risk. And is their CRP greater than 20 or their ANC greater than 10,000? And if yes, they were considered intermediate risk. So most people in practice, I think, apply to high risk stratification for those infants. And if none of those were present, the infant was considered low risk. And this was an algorithm that had similar sensitivity to the historical algorithms and used a procalcitonin-based approach. So I think what certainly changed our practice at Yale, and this is the algorithm we've adopted in our pathway as of the past approximately 3 years, was the PCARM prediction rule, which I think is becoming more widely adopted across the United States now. So this PCARM is a multi-center. This is 26 sites, multi-center, federally funded research group that has done a lot of the landmark studies in pediatric emergency medicine for various topics. So they prospectively enrolled 1,821 infants, randomly divide the infants into a derivation and a validation set. You can see here the percentages of UTI and IBI were similar to what's reported historically. So this cohort was representative of febrile infants in the first 60 days of life. And so using recursive partitioning analysis to determine both what the predictors were as well as their optimal cut points, the PCARM prediction rule was derived as follows. So urinalysis positive, ANC greater than 4,090, procalcitonin greater than 1.71. And if none of those factors were present, the infant was classified as low risk. In the original sort of derivation and validation study, there were 3 infants aged 29 to 60 days who had a UTI or IBI who were misclassified as being low risk. 2 had UTI and 1 infant had bacteremia, but there was a question of whether that bacteremia was true bacteremia versus occult bacteremia. I think what is really, what we really like about the PCARN rule, and it ties into the guideline recommendation about positive inflammatory markers in this age group, and that you may obtain an LP, you may admit. So the PCARN rule is not binary. And so what they did through recursive partitioning is identify what if the ANC was greater than 4,090. Well, there's another branch point, and if the procalcitonin was less than or equal to 0.18, or alternatively not greater than 0.18, that infant was likely also considered low risk, and that there was only 1 infant in this particular age group out of 181 who had a bacteremia, and this was bacteremia with Staph aureus. And so it's likely that infants who have a positive ANC, but a very low procalcitonin, are also low risk. And that's why, to me, going back to the guideline recommendation, to me, the procalcitonin, certainly there's been multiple studies that have shown that it has the optimal test characteristics of any biomarker. And I think if the ANC is positive, but the procalcitonin is normal, personally, I feel that those infants are likely low risk as well. And there perhaps could be shared decision-making around the decision to do a lumbar puncture, or even depending on the clinician's risk tolerance and the parents, perhaps not doing a lumbar puncture for just a positive ANC alone, versus if the procalcitonin is high, my personal practice is to obtain the lumbar puncture. Currently, though PCARN will be hopefully soon. They presented the validation, the external validation of this rule at Pediatric Academic Society's meeting about 1.5 years ago. Hopefully we'll be publishing that soon, which I think will also provide more guidance in terms of which biomarkers to use and how to classify infants with a positive ANC but a low PCT. PCARN then appropriately rounded the cutoff to an ANC of 4,000 and a PCT of 0.5 to make them more easily remembered cutoff points. And these actually align, as you'll recognize, with the guideline, where the guideline really recommends ANC of 4,000 and a PCT of 0.5 as being abnormal. And the test characteristics of the PCARN prediction rule were very similar with the rounding of these cut points. And so this is a graph that compares the performance characteristics of 2 of the historical low-risk criteria, the Rochester and the modified Philadelphia, which don't include CSF testing, with the step-by-step approach and PCARN. The x-axis is the percentage, and then the y-axis is each of the algorithms. The solid bar is sensitivity, and the checkered bar is specificity. And I think what you can see here is only looking as you sort of go down, that the PCARN rule certainly has the highest sensitivity, though most of the rules do. But what the real strength of PCARN, the PCARN prediction rule, is that it has the highest specificity. And the reason that's highest specificity means fewer false positives, which means hopefully less unnecessary lumbar punctures, hospitalizations, and antibiotic therapy. And that's the real strength of using the procalcitonin-based rules, and particularly PCARN, is the higher specificity. Just to give you some context of where the ANC value of 5,200 came from, this was a study that we published about 3 years ago. It was a case control study, multi-center, including 11 sites, where we used logistic regression to identify predictors of invasive bacterial infection amongst febrile infants aged 60 days or younger. We identified 5 predictors. This is retrospective data, so case control study. And you can see the age cutoff at 21 days. Again, it shows up in multiple studies that's sort of part of the reason why that 21 days and below age group is considered higher risk, highest temperature, including that 38.5 cutoff, abnormal urinalysis, and then ANC of 5185, which was rounded to 5,200. Sort of looking at this score and the performance characteristics, if you use a score of 2, which would be an infant of any age who's febrile at home, but afebrile in the ED and has a normal urinalysis and a normal ANC, sensitivity is very, very high at 99%, but the specificity is low. So this, again, goes comparing it to the PCARN rule, for example, the other procalcitonin-based algorithms, that the specificity is really lower when you don't use procalcitonin. But this ANC cutoff was incorporated into the guideline. This was a recent study published by Brett Burstein from Montreal. This was single center, so just one caveat there. But what he looked at was the diagnostic accuracy of the AAP recommended risk stratification using CRP, ANC, that 5,200 value, and a maximum recorded temperature of 38.5. And I think what you can see is this is sort of for IBI specifically, so bacteremia and bacterial meningitis, that sort of across age groups and overall, the sensitivity of this combination was 100%. the specificity hovering somewhere in the 40s. If you then use an ANC of 4,000 instead of 5,200, again, the sensitivity is 100%, but the specificity is a little bit lower, 30 to 40%. So comparing this sort of side by side, specifically looking at the performance characteristics for invasive bacterial infections specifically. Again, the single center data, but the temperature plus ANC plus CRP appears to have high sensitivity, but a specificity somewhere in the 40s. When we compare that to the PCARM prediction rule, sensitivity is similar, 97%. That's combined derivation and validation, but a significantly higher specificity at 61.5%. And then again, this really speaks to the strength of the procalcitonin-based algorithms. So what's the bottom line? The bottom line is you have procalcitonin readily available in the emergency department, or certainly in the office setting if it's available there as well, is to recommend to use procalcitonin-based algorithms. And that's what the AAP CPG recommends. The PCARM prediction rule, again, has similarly high sensitivity, but higher specificity than using sort of temperature plus ANC plus CRP. If PCT is not available, using temperature plus ANC, especially with that 5,200 cutoff, plus CRP has high sensitivity but lower specificity, though again, that sort of combination of predictors needs to be evaluated in a multi-center fashion. No algorithm is 100% sensitive for IBI. And so in this aligns with the guideline as well. If an infant is low risk and you're discharging them home, we really need to ensure close primary care follow-up within 24 hours, provide very clear and detailed discharge instructions for the low but non-negligible risk that the infant could have a delayed diagnosis of invasive bacterial infection, specifically bacteremia. So what about this a recommendation around using selective lumbar punctures in febrile infants with positive urinalyses? So the basis for this, or the conundrum really, is that all risk stratification algorithms, historically and currently, use a positive urinalysis as a quote, high risk, or probably more accurately, non-low risk criteria. And so the general recommendation historically has been to obtain a lumbar puncture and to hospitalize infants who are high risk, including for a positive urinalysis. Of course, the antimicrobial treatment for UTIs differs in dose, duration, and also antibiotic route versus bacterial meningitis. So it's a different antimicrobial treatment. We know that from several studies that the prevalence of bacteremia amongst febrile infants aged 60 days of age or younger with urinary tract infections is somewhere around 6.5%. The real question is, what's the prevalence of bacterial meningitis amongst infants aged 60 days or younger with positive versus negative urinalysis? Is there a difference? Well, Brett Burstein, again from Montreal, published a systematic meta-analysis about a year ago in JAMA Network Open, in which case he did a very, very comprehensive review of the literature, both prospective and retrospective studies, identified 25,374 well-appearing full-term febrile infants, 29 to 60 days. Depending on how he defined meningitis, there were varying numbers of infants with positive versus negative UAs included. I'm showing you one, sort of using one definition. In this definition, there are 4,737 infants with positive urinalyses, over 20,000 infants with negative urinalyses, and the prevalence of bacterial meningitis was almost equivalent between the two groups, infants with positive versus negative urinalyses at 0.25 versus 0.28%. And no matter how we define meningitis, the prevalence was essentially almost the same between infants with a positive versus negative urinalysis. I show you this forest plot from the study just to show that in most of the studies here, there was zero event rate, meaning there were zero infants with bacterial meningitis amongst infants with a positive urinalysis, and the odds ratio comparing infants with a negative versus positive urinalysis was essentially at 1, so there's really no difference. So I think that sort of what we conclude from that data is that the prevalence of bacterial meningitis amongst febrile infants aged 60 days or younger is independent of a positive urinalysis. The positive urinalysis alone does not increase the risk of bacterial meningitis. The question is really, what is the risk of a delayed diagnosis of bacterial meningitis amongst febrile infants aged 60 days or younger treated with antibiotics without LP? So if you don't do the LP, treat them with antibiotics as the guideline recommends, what's the risk of having a delayed diagnosis or some adverse outcome? There are a couple of studies that have looked at this topic. This was a study, retrospective cohort study out of Kaiser Permanente in Northern California that included 341 infants, 29 to 60 days of age, who had a positive urinalysis, who were treated with antibiotics without having CSF obtained. And there were no cases of missed meningitis and no severe sequelae with 30-day follow-up. Marie Wang and colleagues used the original revised data from several years ago, included about 124 sites, both academic and non-academic sites, and they had identified retrospectively 734 infants aged 60 days or younger with a positive UA treated with empiric antibiotics without having CSF obtained. Approximately 2/3 of the infants received a full course of treatment for UTI, and about 1/3 received antibiotics that had a negative culture, presumably, and then were not treated for UTI. And in both groups, there were 0 cases of meningitis, with a combined sort of prevalence of meningitis amongst these infants of 0%, with a very tight 95% confidence interval. The one caveat being the follow-up period was 7 days, and of course, it was retrospective data. So the question is then, can we predict which infants who have a positive urinalysis have bacterial meningitis? So this was a study, it was an ambidextrous study. It was a single center derivation using a prospective registry, followed by a multi-center validation. And this is really identifying predictors of IBI, so bacteremia and meningitis together, done in 21 European EDs. And what they identified, Roberto Velasco was the lead author, is that infants who had age over 15 days, or not less than equal to 15 days, PCT that was less than 0.6, so again, right around that 0.5 cutoff, in CRP that was less than 20, those infants were sort of low risk. So you had none of these predictors listed here. Your infant was considered low risk for IBI, so bacteremia and meningitis together. In the derivation set, they included 662 infants. Sensitivity was reasonably high for IBI together, and the only one infant was in the derivation set who had a bacterial meningitis, and that infant was classified as, quote, high risk. In the validation set, the 449 infants, the sensitivity was 100% for IBI, meaning no missed cases of bacteremia or bacterial meningitis. But unfortunately, there were no, or I guess I should say, fortunately, in the big scheme of things, but from sort of an evidence base, there were no infants with bacterial meningitis included in the validation set. Though I think what I sort of conclude from this is that infants in this age group who are sort of older than that 15 to 21 day age group with normal inflammatory markers are probably very, very low risk for having common bacterial meningitis, possibly bacteremia, though we need more evidence around that. The question is when should you obtain an LP on a febrile infant with a positive urinalysis? And for that, I sort of shrug my shoulders and say, I'm not sure. I think certainly if the infant is ill appearing, I would say certainly right now, and this aligns with the guideline, in the first 3 weeks of life. And I would say for me, personally, I think I would certainly strongly consider an infant with a positive procalcitonin. I think the easier question is when should you not obtain an LP on a febrile infant with a positive urinalysis? I think the evidence base is pretty clear now that infants 29 to 60 days of age who are well appearing and have negative inflammatory markers do not need a lumbar puncture. The positive urinalysis alone does not increase their risk of having meningitis. We still need caution in infants in the first 3 weeks of life. And of course, as just recognizing the sort of small risk of meningitis overall in febrile infants, especially those with a positive urinalysis, there are very small numbers of infants with positive urinalyses and meningitis that are reported in the literature. And so when I go back to the PCARM prediction rule, which is again the rule that we use in our pathway at Yale, and we look at the rounded cutoffs, as I'm shown before, that urinalysis was sort of the strongest predictor. But I think now, given this sort of evidence base, I think in this what the guideline recommends, I would flip this. Is first you look at inflammatory markers. Is the PCT over 0.5? Is the ANC over 4? And again, for that age group, if the PCT is less than 0.18, that infant's probably also low risk. And then really a urinalysis positive alone with negative inflammatory markers, that infant still is low risk for meningitis. And certainly it can be treated for presumptive UTI, but does not need a lumbar puncture routinely. So now we're going to go to the algorithm for febrile infants 22 to 28 days old. And I say this for last, even though there are some similarities to the 29 to 60 day age group, but I think there are some important differences. So very similar to the older age group, the recommendation is to obtain a urinalysis, sending urine culture if the urinalysis is positive, a blood culture, and then using inflammatory markers to further risk stratify the infant. If the inflammatory markers are positive, in this age group, the recommendation is to perform a lumbar puncture, to admit the infant, including if the infant has a positive urinalysis. So regardless of inflammatory markers, a positive urinalysis would result in admission in this age group. To use ceftriaxone if the urinalysis is positive or the inflammatory markers are positive, but the CSF is negative, and to use ampicillin and ceftazidime if you're concerned about meningitis based on the CSF. If the inflammatory markers are negative, even with a positive urinalysis, the recommendation from the APCPG is to do shared decision-making about lumbar puncture. And we'll talk about shared decision-making in just a moment. If that decision is made to not obtain a lumbar puncture, the recommendation is to admit off antibiotics. So when you really have that shared decision, the decision is do a lumbar puncture, yes or no. If you don't, you would admit off antibiotics. If the decision is made to obtain a lumbar puncture, the recommendation is to do another shared decision around admission to the hospital versus discharge if the CSF is negative. If you're not doing a lumbar puncture, you can admit off antibiotics, and that's certainly what I've done in my practice when that decision is made. If you are discharging the infant after a negative CSF, the recommendation is to give ceftriaxone prior to discharge home. So we're going to spend a couple minutes talking about shared decision-making with parents of febrile young infants, which is another sort of area of interest of mine. So what is shared decision-making? So this is the process in which clinicians and patients, or in our field of pediatrics, parents or guardians, make healthcare decisions together, taking into account the best medical evidence in either the patient or the parent's values and preferences, with values being really what's important to the parent in making that decision. This is really critical to achieving patient and family-centered care and ultimately patient-centered outcomes. And through some qualitative work we've done, one clinician said this as to terms of defining shared decision-making, which I like: incorporating the family and patient when it's appropriate into medical decisions. And so this is the publicly available AHRQ share approach, which shows the 5 essential steps of shared decision-making. The first step is to seek your patient's participation. This is a really important step, particularly thinking about health equity, and that we really should not make judgments based on which patients or which families we think want to participate in shared decision-making. We should approach it based on the guideline recommendations and approach all parents, regardless of race, ethnicity, regardless of language preference, equally, and seek their participation in making a decision. Now, some parents may ultimately defer the decision to the physician or to the clinician. That is appropriate. We need to approach them all equally. We then help the patient or the parent explore and compare treatment options, or in this case, for example, the option of obtaining a lumbar puncture versus not obtaining a lumbar puncture, talking through the risks and benefits. We then assess what their values are, what's important to them in making the decision, and whether they have any, what their preferences are. We certainly can bring our own preferences into the decision-making, but it's really important to understand the patient, or in our case, often the parent or the guardian's values and preferences first, before then incorporating our own. We then reach a joint decision with the patient or the parent, and then ultimately we evaluate the patient or parent's decision, which means kind of looking back to see what was the outcome. Do we not do a lumbar puncture? Did the infant have meningitis or not? Do we do a lumbar puncture? What was the result? So just using one example, this is a screenshots from an app that we developed, did usability and field testing with. This app has not been tested for efficacy, also so needs a lot of revision, and so it's not ready for prime time at all in the setting that it needs to really be shown for efficacy. But I show this more as an example of some of the language that you could use to do shared decision-making with parents in this 22 to 28 age group. So for example, you can introduce the fact that the results of the urine and blood test mean that the baby probably does not have bacteremia or bacterial meningitis. And then what you could say is something along the lines of estimated up to 1 out of 1,000 or 0.1% of babies with fever sort of in this age group, in this setting, have bacterial meningitis. The risk is low, but bacterial meningitis is a very serious infection. Because of this, doctors may differ whether they recommend a spinal tap versus not. It's really important for us to learn what's important to you in thinking about performing or not performing a spinal tap. And then we go with what's called through a value clarification exercise. This is text from the app, but this can be done verbally as well. That you really sort of then walk through that sort of features of doing a spinal tap versus not doing a spinal tap with the parent, of course, using health literacy friendly language that's appropriate. So, for example, how is bacterial meningitis found? If you do a spinal tap, here's how it's found. If you don't do a spinal tap, here's how it's found. What are the possible results? What's important? If you do the spinal tap, you may obtain it may be negative, you may obtain it may be positive, or you may not obtain it. Then what happens then? If you don't obtain the spinal tap, the infant may just go home or be admitted off antibiotics and do well, or they may have a delayed diagnosis, sort of walking through the different scenarios. What are the benefits of one choice versus the other? And ultimately, what are the risks? What are the risks of spinal tap? Ideally using numbers if you can. And then what are the risks of not doing a spinal tap? Again, using numbers. This is approximately taken from the guideline that the risk of having bacterial meningitis in an infant 22 to 28 days old with negative inflammatory markers is 1 out of 1,000 or 0.1%. When people in shared decision-making world use things called decision aids, which are sort of, they're handheld or electronic tools to help guide the decision-making process. They often use icon arrays such as this, where you sort of have, like, for example, 1,000 sort of gray figures representing the denominator, and then one red person to show that out of 1,000 babies in this scenario, 1 will have bacterial meningitis. Again, I think right now, what the guideline really recommends is to do a lot of this verbally, and that's what I've done in my practice, is sort of adopt this sort of a modified script like this into a verbal discussion with the parent or guardian. So a couple last topics before we end and take questions. So one is time to discharge. And what the guideline recommends for all age groups is that the infant be discharged at 24 to 36 hours if the bacterial cultures are negative and the infant is clinically improving. So this recommendation is based on several studies that have been done. I'm going to show you a couple of them here. The first, well, not really the first, but a big one was done by Eric Biondi and colleagues. And they had about 360 infants with bacteremia, of whom 91% of infants with bacteremia, 91% of pathogens were resulted within 24 hours and 96% within 36 hours. The point being here, the vast majority of pathogens in the blood will be identified within 24 to 36 hours. This was a multi-center study that we did several years ago. Well, we had 360 infants with bacteremia, 62 with bacterial meningitis. What we found is somewhere around 88%, with a little bit of a higher percentage that the infant was ill-appearing of blood pathogen identified at 24 hours. And again, similar to the Eric Biondi study, 95% identified within 36 hours. Looking at CSF, 89% of CSF pathogens were identified within 24 hours and 95% within 36 hours. And of course, there's always a challenge of defining bacteremia and meningitis in terms of what is considered a pathogen in this age group. So it's possible that some of the delayed diagnoses beyond 36 hours were not actually true pathogens. So kind of doing the math and sort of marching it out, if the baseline prevalence of IBI is 2% amongst febrile infants, that if you observe every infant beyond 24 hours, you'll identify one additional infant with bacteremia for every 500 infants evaluated. If you observe in all infants beyond 36 hours, you'll identify one additional infant with bacteremia for every 1,000 infants evaluated. So that sort of point is that most infants do not have these infections. So observing them beyond the recommended guideline recommended 24 to 36 hours, it really has diminishing returns. So the last topic that I'll touch on is respiratory viral testing. As I mentioned up front in the guideline, that infants with clinical bronchiolitis are excluded from the guideline because they, as I'll show you, probably have a lower risk of having this particularly invasive bacterial infection. Positive respiratory viral testing alone, including URI symptoms alone, does not exclude the infant from the guideline. And so I'm going to show you a little bit of the evidence for that, given that, as I showed you, it's not really part of the guideline recommendation. So first is COVID-19. It's only always a topic that comes up a lot. I certainly in recent months have had multiple febrile infants who have tested positive for COVID-19 while in the emergency department. So the question is, what's the risk of having, or what's the prevalence of bacterial infection, UTI, IBI, amongst infants who are test positive for COVID-19? Unfortunately, for right now, the best data we have is using 2020 data and included low numbers of infants. The studies I'm going to show you are two studies that included a total of about 70 some odd infants, 70, 80 infants between them. And what they basically found is that the UTI prevalence was somewhere around 5 to 6% in infants who are COVID-19 positive versus 23 to 30% if COVID-19 negative. I want to highlight this 23 to 30% prevalence of UTI is significant, 2 to 3 times higher than what's been reported historically. And this is all using 2020 data. And so what we think then is, so back then the emergency department visits went down, presumably due to less circulating viruses that were non-COVID-19. And so febrile infants who presented, the theory is that most, that very few of them had respiratory virus infections. So the baseline prevalence of these other infections were higher, not because the bacterial infections went up in incidence, just because there were very few infants who had positive respiratory viruses. So you have to sort of take some of these data with a grain of salt, and that the baseline prevalence of infection in these studies is much higher than what's been reported historically. And I think that's what we're seeing now. The bacteremia prevalence ranged from 0 to 15% if COVID-19 positive versus 4 to 24% if COVID-19 negative. And then meningitis prevalence, there were 0 infants with COVID-19 who had COVID-19 who had meningitis. So again, very, very small numbers of infants versus 0 to 7% if COVID-19 negative. So sort of looking at these, I think studies were a bunch of caveats from what we have now. Is one, that the prevalence of UTI and IBI, as I mentioned, was much higher in 2020 than the historical prevalence. I think for these studies, and they were small studies, there was really sometimes an unclear definition of UTI and IBI, and ultimately there were very, very small numbers of COVID-19 positive febrile infants. So we really need more data on this topic. I currently, as Jeff Louis mentioned, am co-leading the Revised 2 Quality Improvement Collaborative, of which your hospital is participating, includes approximately 100 sites across the US and Canada. We are still sort of piecing through our data. The goal of the project is really to implement several recommendations from the guideline and improve adherence to evidence-based care for febrile infants age 6 days or younger. We have been capturing data on infants who are COVID-19 positive, and sort of a quicker look at the data. What we're finding is that I think that the prevalence of UTI and IBI is really on the lower end. So looking at these sort of numbers from these single center studies, I think our numbers are very much on the lower end or on the low end. Of course, higher amongst UTI than IBI. We really need to sort of piece through the data much more. I will say the risk is not zero. I think that's what's going to be shown in other studies as they come out. So I think COVID-19, we still don't know exactly what to do with it. I think the risk is probably lower of having infection for infants who are COVID-19 positive, as a lot of this data has shown, but we really need more data on to show what the exact, at least estimated prevalence is and how that changes the risk stratification algorithms that we have. So I think right now it's unclear what to do in the setting of an infant who's COVID-19 positive. What about other respiratory viruses? So this was a study prospective looking at, this is from PCARN from several years ago. And what this table shows is infants who are virus positive versus virus negative, with each row representing a different type of infection. And I think what you can see here is the infants who are virus positive, for example, looking at the top row, had a 3.7% prevalence of either UTI or IBI, which was almost 3 to 4 times lower than infants who are virus negative. Most of those infections were UTI, though there was a non-negligible prevalence of bacteremia and bacterial meningitis amongst infants who were virus positive. I will say PCARN presented again at PS about a year and a half ago. Their prediction rule, again, I mentioned their validation before, and they also looked at how virus testing alters the performance characteristics of their rule. And sort of my take home from the presentation at the time was that their rule already is highly sensitive, is already more specific than prior rules. Their virus testing probably doesn't significantly change the performance characteristics of their rule, which is part of the reason why these studies have not been incorporated into the guideline. But I think that hopefully PCARN will be publishing that data soon, so we can look at it, and then we can sort of have more definitive answer around how to incorporate viral testing when you're using procalcitonin, for example. This was a study, the Intermountain healthcare system in Utah from several years ago. And what this looked at is sort of looking at all infants who were tested for viruses. And I think that sort of take home here is the different lines represent sort of different age groups. This is up to 90 days old. And what you can see is infants who were virus positive, but were non-rhinovirus positive, had a total prevalence of infection of about 3.7%. Most of that was UTI. Rhinovirus positive infants, though, had a higher prevalence of infection, 7.8%, which was certainly lower than infants who tested virus negative, which was 13.4% prevalence of UTI or IBI. I think what this showed, what the take home from this was, is that rhinovirus is a very, very sensitive PCR, and that may be picking up infants who, for example, had rhinovirus a week or two ago and may not be the source of their fever currently. And so this sort of study really recommended caution in approaching infants who had a positive rhinovirus, and probably approaching them similar to infants who are virus negative. Sean Ralston, who this study is now 10 years ago, is a meta-analysis looking at the prevalence of the risk of UTI and then bacteremia and meningitis amongst infants with bronchiolitis. So this is bronchiolitis specific, not necessarily virus positive, but bronchiolitis specifically. The data is a little bit old, but I think this is still relevant today, is that when we look at UTI, that combining the studies, mostly retrospective, some prospective studies, the prevalence of UTI amongst infants with bronchiolitis in that first 6 days up to 9 days of life was 3.3%, so non-negligible. So I think that thinking about infants with bronchiolitis, obtaining a urine is certainly recommended. The prevalence of bacteremia was very low, and actually most of the studies had zero event rate, meaning there were 0 infants who had bronchiolitis and bacteremia. And so, as Dr. Ralston put in this, she wasn't able to provide a summary statistic just because there were so many 0 event rates. And similar, meningitis also was very, very, very low risk, mostly zeros in the different studies. And so I think with bronchiolitis, the risk of bacteremia and meningitis is lower, but it's non-zero. And so I think a lot of us in the first 3 weeks of life certainly approach it very similar to infants without bronchiolitis. And then there's some variation in practice around the obtaining of blood cultures, for example, and blood testing infants above 21 days. And this is why these infants are excluded from the guideline, because there's sort of a little bit of a gray area that people may approach these infants with a more risk tolerance, particularly in the second month of life, who have clinical bronchiolitis. So what's the summary? So the summary is that the evaluation and management as per the AAP CPG really differs by age. In infants 8 to 21 days, the recommendation is for the full workup, including lumbar puncture, admission, again, for all age groups, sending a urinalysis without automatic urine culture and inflammatory markers are optional. For infants 22 to 28 days, using a procalcitonin-based algorithm if procalcitonin is available, and performing shared decision-making about lumbar puncture and hospitalization if inflammatory markers are negative. While infants in 29 to 60 days, again, using a procalcitonin-based algorithm, discharging home if inflammatory markers are negative, not doing an LP and if the inflammatory markers are negative, and to treat with oral antibiotics if the urinalysis is positive and inflammatory markers are negative. So the last thing I'll mention is this is also work done by PCAR, and hopefully we'll have more data on this soon. This is RNA Transcription Biosignature. So PCAR, through the prospective cohort, has been evaluating the test characteristics of RNA transcriptions biosignatures, which are really the gene expression leading to the mRNA expression from peripheral white blood cells in response to different types of infection. The idea is you take a small amount of blood and you run this microarray panel, and essentially this will different genes will light up based on virus infection versus specific bacterial infections. And so the hope for this could be like a one-stop shop in the future where you just run some blood and determine virus versus bacteria. The original pilot study showed high specificity in particular, as well as reasonably high sensitivity. But of course, this needs to be validated in a larger sample, and also things like cost and cost effectiveness also need to be evaluated. This may be the future of where we're going. Just to end my talk, I just like to give acknowledgments. I've been very fortunate, certainly in not just in pediatric emergency medicine, but throughout my career, having many, many wonderful mentors in some of the work we've talked about today and my work in general, many of whom are shown here, including many wonderful women mentors I've been very fortunate to work with. Also want to acknowledge Corey McDaniel, who's a hospitalist at Seattle Children's Hospital, who co-leads the Revise 2 project with me. And also want to thank Dr. Jeff Louie for inviting me to give grand rounds. And also Jeff and I have collaborated through the PEMCRC on several studies, and you're all very fortunate to have him leading the division of pediatric emergency medicine at your hospital. And so I'll take any questions, and just to distract you from asking any tough questions, these are pictures of my children when they were young infants. Though of course here they are more recently. And I'll stop there and take any questions, and thank you so much for your attention and time.
Well, thank you, Paul. That was amazing as usual. I have a question. I have two questions for you. One is, in one of your papers, you talked about hypothermia at home, but then presents in the emergency departments with no fevers. And if the workup, which include the procal, I think the procal and ANC and urine are negative, then it's safe to send home. But what if, I mean, and I've done this, I followed your rule or your guidelines, but what if the temperature was 103 at home and febrile in the ED 12 hours later? Do you treat that differently?
So sorry, say what temperature home is 100.3, is that what you said, Jeff? Sorry.
103.
Yeah, so this is a good question. So I think this, in our study, we looked at the combination of predictors, and then we sort of in that, had a chart of essentially like the more points you have, here's the sensitivity and the specificity. So as you sort of go up, like the temperature is high, but the other factors are lower, the sensitivity will sort of go down, but the specificity goes up. I think the guideline sort of uses that temperature cutoff of 38.5 or 38.6 and higher as a sort of inflammatory marker. So I think based on the guideline, a temperature of 103 at home within 24 hours prior to presentation would qualify as a positive inflammatory marker, which means that infant would no longer be low risk. I think it's a question. I think what we know about temperature from the literature is that temperature has lower specificity. Definitely, the higher the temperature, more likely you have bacterial infection relative to lower temperatures, but there's a lot of crossover. And so I think in that particular scenario, I think this is a challenge for us. I think this is, again, the beauty of procalcitonin is that you can not say ignore the temperature completely, but you can use an algorithm that's been validated prospectively and does not include temperature. I think that in your case, I would still apply caution. I think this is also why the guideline, especially in that 29 to 60-day age group, recommends a lot of sort of risk tolerance discussion and engagement around infants with a positive inflammatory marker. Meaning for that infant, 103 at home, looks great in ED, maybe you do other tests, you do ANC, CRP, they're all negative. So all you have is this high temperature at home at one point in time. To me, in my practice, the infant's well appearing is a good opportunity, potentially also applying the guideline for shared decision making, thinking about what's the practice environment you're in? Can you guarantee follow-up? Does the infant have viral symptoms? Did the infant test positive for COVID, for example? And to me, even though the data on COVID, we still need more of it, that may influence my decision-making around it. So I think I don't have a great answer outside of say to me that using temperature alone, with everything else being negative, I would, to me, is a good opportunity in that older age group for really engaging your own risk tolerance, the parents, perhaps a pediatrician, and sort of deciding where on the risk sort of spectrum you fall in regards to lumbar puncture admission and hospitalization. I think most of those infants are not going to have bacterial meningitis, but technically they have a positive inflammatory marker. And so I think you just have to be cautious and sort of really just combine everyone's risk tolerance, if that makes sense.
Robo has one of my partners has a question about hypothermia. And I know you've actually published on hypothermia, but hypothermia is like what 96 and less, but there's always those kids who present like 96.5. I mean, is there enough data to stratify those kids into risk less than 97?
Yeah, that's a great question. So I will say, I'm going to say that there's been a little bit of research. This is an area of more need. And there's a researcher named Ram Ramgopal, who's at Lurie Children's, who's published a couple papers on this. And sort of my interpretation from his data right now is that we still do not know how to best risk stratify infants with hypothermia. I think a lot of us apply the AAP guideline type risk stratification to them. That really hasn't been validated. And that's really just sort of extrapolating one sort of population to another. From what I've seen in terms of Ram presenting and discussing is that it's unclear what the cutoff is, that the sort of identification or prevalence of, for example, invasive bacterial infection using a 36.0 Celsius cutoff versus 36.5, they're marginally different. And so we don't actually know what the optimal cutoff is right now. And I personally, in our sort of ER, a lot of us, I think, use 36.0, which I think strap was out to 96 point something. But I do know that Ram Ramgopal is planning to sort of hopefully over, it's going to take a couple of years to get the data, but using a multi-center project is hopefully going to give us better answers on what's the optimal hypothermia cutoff in terms of like the balance of sensitivity and specificity for invasive bacterial infection. Can we use sets of predictors? But I think right now we just don't have the data available. All we know is that a non-negligible percentage of those infants will have a more serious infection. You got to think of HSV as well. So in the first 3 weeks of life, maybe the first month of life, but we don't really know. So I don't have a great answer for that outside of just that the cutoff probably falls somewhere between 36 and 36.5, and it's been used in different studies, but we don't know right now. But hopefully Dr. Ramgopal will give us some answers over the next couple of years.
Great. Another question from Dr. Kyla. What about the WC of less than 5,000 and greater than 15,000 with a normal ANC and normal procal? Did you look into that? And if yes, did they all have normal? I guess it's in inflammatory markers.
Yeah, so great. So you really asked about the white blood cell count. So historically, so I trained as Dr. Louis mentioned, I trained in Philadelphia, and when I came to Yale over a decade ago, we used the Philadelphia criteria, which in my residency, when I was intern, I thought this was it. We've done febrile infants. Well, everyone uses Philadelphia criteria across the world. Of course, that's not the case. And of course, things have evolved substantially since then. So Philadelphia used band count plus a white blood cell count of 5 to 15,000 as normal. Rochester criteria is similar. And essentially, multiple studies have now shown that white blood cell count, the performance characteristics it's almost like 50-50. And the white blood cell count alone predicts very little, certainly in febrile infants, compared to ANC, compared to CRP, compared to procal. So the guideline specifically says not to use the white blood cell count for risk stratification, to use, again, these sort of more sort of newer risk stratification algorithms. Question comes up though is you risk stratify as you have, and the white count comes back as low, 3,000, 2,000, for example. The ANC is low, PCT is low. So what do you do then? You just ignore it. I would say based on the PCARN rule, which is again what you use, I think that ignoring the white blood cell count is appropriate. Meaning, I will say in their study, and they published this in 2019, their original derivation and validation study, of the very few infants, the 3 infants who were misclassified as low risk, some did have a low white blood cell count. And so on the flip side, though, I think really sticking to the algorithm, I think most of those infants, I think if you use white blood cell count, you're going to, again, lower the specificity of the rule. Is it possible you pick up like one additional infant amongst the many hundreds who don't have bacteremia, who then have it? You could. I would say in my general practice, I do not look at the white blood cell count. I use the algorithm as they're supposed to. And I think that the white blood cell count just probably lowers the specificity with only a marginal increase in sensitivity. That being said, the last thing I'll mention is that I think using your clinical judgment is also appropriate. So for example, on a recent shift, I had a febrile baby who had diarrhea, whose temperature was high. So above 39. So we very similar case, actually, what Dr. Louis was mentioning, who I risk stratified using the PCARN rule. Procalcitonin was normal, ANC was normal. They actually had 20% some odd bands. So band count we know is unreliable, and that is not included as part of the rule. So the question is, now what? Do I just ignore that? Now, part of me is, this is based on my historical sort of practice, is I had some infants in the past with high temperatures, bands, diarrhea, who had salmonella and invasive disease. And so that was my suspicion. We sent a stool pathogen PCR. I actually admitted the child, and they ended up having salmonella. And so I think there's also clinical judgment there, where I think that, again, the rules are intended to be as applied as they are, and that they have high sensitivity and high specificity. But of course, based on various factors, individual clinician judgment, and this is all throughout the guideline, that the guideline is meant to be a guideline, and incorporating your own risk tolerance, the parents or guardians' risk tolerance is really important. I think there's also that room for sort of judgment as well, recognizing where the evidence base is, but then using your judgment as you deem appropriate.
Emily, one more question. So here's a question from Sarah Swenson. Is there a lower gestational age below which procalcitonin is less useful? Is procal the most useful marker in the first few days of life, or first week of life?
So that's a good question. I'm going to say I confess that I do not know that there's data on this topic. And so part of that is that when you look at prematurity, and the part of the reason it's excluded from the guidelines, so infants less than or equal to 37 weeks gestational age. So those infants were excluded from, for example, the PCARN study excluded infants gestational age of 36 weeks or lower. The thought being that those infants are considerably higher risk, they have more immature blood-brain barriers, et cetera, more immature immune systems. They were actually excluded. So we don't actually know. I think, and you also bring up the idea of, like, procalcitonin. Can an infant who's 3 days old with a fever generate sort of enough of a procalcitonin response? We know certainly from some data from out of Spain and others that procalcitonin can be falsely negative in the first 6 hours in particular of a febrile illness, and that takes a little bit of time to sort of go up. And so if the infant, for example, develops a fever at 10 a.m. and presents to ED at 10:30 a.m., procalcitonin conceivably could be falsely negative. That's been shown in some studies, but I don't know in terms of age or prematurity. It's a great question. I think that's part of the reason why those infants are excluded from the guideline, is we don't have the data, but we also need more data. The challenge is those infants have often been excluded. So I don't know that answer, but I think my general practice has been to apply caution in that age group. And so in the younger infants in the first week of life, I think most of us, infant has a fever, infant has true hypothermia, that I think we're going to approach those infants, conservatively, meaning lumbar puncture, admission on antibiotic. I think that first week of life is the high risk age group, especially if they were similarly premature. And so that's sort of at least my extrapolation. I think many of our extrapolation of the data that we have.
Great. I think that's the last question. I think, and time's about up. Paul, I want to thank you so much for doing this Zoom virtual grand rounds, and I look forward to seeing you in the near future.
Yeah, thank you all so much. And feel free, anyone wants to email me, Dr. Louis and others have my email address. I'm always happy to sort of answer questions or have a discussion about this stuff. And again, it was such a pleasure to talk with you all. Thank you so much.
Thank you.
Thank you so much for being here. Have a great Wednesday, everybody. Bye.
Bye.